Good morning, everybody. Good morning, everyone, and welcome to the Royal College of Pathologists of Australasia, our celebration for International Pathology Day 2025. My name's Sophie Scott. I can see lots of familiar faces in the audience. I'm going to be your MC for today. I want to start by acknowledging the traditional owners on the land we're meeting, the Gadigal people of the Eora Nation, and pay my respects to elders past and present, and also acknowledge any Indigenous guests joining us in person or watching online. For those of you that I don't know yet, I was the medical reporter for ABC for quite a few years, so I've interviewed a lot of pathologists, including quite a few people in the room and watching online as well. And now, since leaving ABC, I work as a speaker on communicating with impact and wellbeing. And I'm really glad that the college has chosen lung cancer as the topic for today. It's something that's been important to me. I lost a very close family member to that disease, so I'm really glad to see more attention to this really important issue. And as we'll probably hear, for many years there's been a lot of stigma about lung cancer, and that stigma has led to people putting off diagnosis and even treatment. And there was a really nice quote on the Lung Foundation website which said, "It doesn't matter how you came to have a lung condition, you are still deserving of care, support and understanding." And so I really thought that was a nice sentiment for today. And thankfully we're seeing change in Australia. And as you'll hear today, lung cancer screening has begun, which is so exciting. And you'll hear about the advances in personalised medicine as well that are making a big difference. We've got two fantastic patients who've joined us today, Martin and Chanel, and we really appreciate them giving up their time to share their experience. And our keynote speakers are going to look at things like molecular testing best practices and the role of liquid biopsies in lung cancer. And then we're going to have a panel discussion where you in the audience here and online can ask questions. So please be thinking about your questions when you hear our amazing presenters speak. There'll be a chance for you to ask questions, and we want your questions. This is your event. It's International Pathology Day, so it's all about you. And I might just get you to grab your phones out. And so everyone, if you can do that for me, just grab your phones. You don't have to take a selfie or anything. Just pop your phone on silent for me. And if there are any emergencies, just follow the RCPA staff guidance. And how many of you are on social media? These days, some people are, some people aren't. If you're on social media, the college has just started up a new account on a platform called Blue Sky. I don't know how many of you are on Blue Sky. It was started up after Twitter, basically to be like the nice version of Twitter, and there are a lot of scientists and medical people on it. So if you are on it, you can follow the college. It's at the RCPA. And I'm on it as well. My handle is Sophie Scott and the number 2. And then if you're on Instagram, you can also follow the college. Their handle there is, it's at _RCPA. And then I'm on Instagram too. Mine's Sophie Scott and the number 2. And then the hashtag for today is IPD 2025. But if you are on social media, why should you share the insights that you hear today? Well, today you're going to be hearing from some of Australia and the world's best lung cancer and pathology experts. And the insights and the information that you hear could save someone's life. So that's why we want you to share it and get the message out to as many people as possible. So to formally welcome you to today's event, please welcome the RCPA CEO, Dr. David Andrews.
Sophie, well, you're definitely our number 1 MC for today. Good afternoon, everyone, and welcome to everyone here and online. I'd like to also acknowledge the traditional custodians of the land on which we meet today and pay my respects to elders past, present, and any Aboriginal and Torres Strait Islanders who may be in the room or online with us today. I'm delighted you could join us to celebrate International Pathology Day 2025. We certainly have an impressive lineup of speakers. Some who are going to share major advances that have been made in diagnosing and treating lung cancer. This is an important conversation to be having during Lung Cancer Awareness Month, highlighting lung cancer as one of the most diagnosed forms of cancer in Australia, but also the deadliest. Today we'll learn how Australia is helping to turn the dial on survival rates and earlier diagnosis and precision medicine for more tailored treatments. I'm looking forward to hearing Professor Vivian Milch from Cancer Australia to discover how the new National Lung Cancer Screening Program has been going since it was launched in July. This year, the College also launched Australia's first molecular testing best practice recommendations for lung cancer, and we have Professor Wendy Cooper with us to share what a game changer this has been. I highly recommend listening to Wendy's interview in our recently released Pathology Report podcast. There's a lot of R's and P's in that. The new recommendations were developed in partnership with our friends at TOGA, the Thoracic Oncology Group of Australasia, and we welcome oncologist Dr. Ben Kong, who will also be speaking today. It's always so great to hear from our clinical colleagues who provide care to patients and who benefit from the advances in diagnosis and treatment. Pathologists are playing a vital role in tackling Australia's biggest cancer killer, and we're excited about how many possibilities presented by the next generation genomic testing. I look forward to an insightful and informative session, and I'm especially delighted that today's closing remarks will be made by the College's newly elected President, Professor Sandra O'Toole. This will be a fitting first public engagement for her, and we're looking forward to celebrating International Pathology Day with all of you. Thank you.
Thank you, Dr. Andrews. So, as David told us, our first speaker today is the Medical Director at Cancer Australia. She's the Medical Advisor for the Federal Government's Department of Health, Disability and Ageing on cancer screening, and also an adjunct clinical associate professor at the University of Notre Dame. So prior to joining Cancer Australia, Professor Milch was a GP and a clinical researcher at the Garvan Institute. Please give a big warm welcome to Professor, she's hiding behind the pole, get her to come out, Vivian Milch.
Thank you, Sophie. So thank you all for being here, and thank you to RCPA for inviting me to speak. I'm hoping my slides will come up. Yes. So I'm Vivian Milch. I'm the Medical Director at Cancer Australia, as Sophie just said. I've also been involved in the lung cancer screening program since Minister Hunt asked us to undertake an inquiry into lung cancer screening back in 2019. And it's been a very exciting 6 years of investigating what a lung cancer screening program would look like for Australia, and working on the implementation of it. And it's incredibly exciting to see it launched on the 1st of July this year. So I'm going to talk to you a little bit about why we've got a lung cancer screening program and what it looks like, and what we've found so far. So why do we need a lung cancer screening program? So lung cancer is the number one cause of cancer death in Australia. It has a huge impact on our society, and it's interesting, Sophie talked about someone in her family. Many of us will have someone in our family or friends who has been impacted by lung cancer. So we know that it accounts for about 16.9% of all cancer deaths in Australia. Huge impact. We also know that the survival from lung cancer is very much impacted on when we find it. If we find it at stage 1 or 2, it has a pretty good cure rate, 5-year survival rate. If, however, we find it further down the track at stage 3 or 4, it has a much lower survival. And we have better and better molecular testing, which Wendy will talk to you a bit about later, and also targeted treatments for lung cancer, particularly for stage 4. But the bottom line is, if we can find lung cancer at stage 1 or 2, treat it with surgery, maybe also radiotherapy or some short-term chemotherapy, we have very good outcomes, and that's what we're trying to do, change the story of lung cancer in Australia. We also know that for many people affected by lung cancer, stigma is a huge issue. Stigma and nihilism, particularly in lung cancer, that it is very much associated with a history of smoking, and for a lot of people, and also a sense that nothing can be done. And we really want to change that story too. So, and then we're very excited to have an announcement in the 2023-24 budget that a national lung cancer screening program would be funded, and we've spent the last 2 years basically putting in place all of the different elements to make sure that program could be launched on the 1st of July and be underpinned by a very strong foundation. So the first thing that happened was that we have 2 new bulk billed MBS items for a low-dose CT scan for somebody without symptoms. This is new. It's new to have an MBS item for radiologists to charge for a CT scan for somebody with no symptoms, but it's also new to have a mandatory bulk billing MBS item, and that is tremendously important because lung cancer disproportionately affects people of lower socioeconomic status, Aboriginal and Torres Strait Islander people, and other people who we knew we didn't want to impact or have any new barriers or any barriers that we could do something about to participate in the program. We have a screening and assessment pathway which has been put together by the College of Radiology and the Thoracic Society of Australia and New Zealand, with input from many of the different societies, including RCPA, the College of GPs and others, and we're very excited by the screening and assessment pathway that we have and the bespoke nodule management protocol that underpins that. We're integrated with the National Cancer Screening Register, which is Australia's infrastructure that sits behind our bowel cancer screening program, our cervical screening program, and now our lung cancer screening program. It manages the data. It invites people, in particular for lung cancer screening, it invites people back for their subsequent screens after they've started participating in the program. We have a national communications campaign which was only launched a couple of weeks ago, and we're using all of the existing low-dose CT scan infrastructure around the country, both in the public and the private setting. And we know that there should be enough infrastructure available for the people who need to be screened, and that's where we're trying to integrate it with our current system. Having said that, we also know there's a lot of people who live a long way away from a low-dose CT scanner, and we have a fleet of mobile CT scanners in development. They're just starting now, and they're going to go to places in the country who are in rural and remote areas, visiting people in the communities where they need them. So eligibility criteria were set by the Medical Services Advisory Committee as people aged 50 to 70 who have no symptoms or signs that suggest that they have lung cancer, because they would go down a different route, a diagnostic route. People who've had a history of smoking and that they either currently or quit smoking in the last 10 years, and that smoking history is quite intensive, 30-pack years. Now that's because people with that history are at high risk of lung cancer, so we know that for those people the benefits will far outweigh any risks or harms of being involved. The screening and assessment pathway, as I mentioned, puts together a way of recruiting people to see their GP. Generally, their GP or nurse practitioner can order a low-dose CT scan after the second step, which is checking their eligibility and obtaining informed consent and shared decision making, ordering a CT scan. They go along and have that at the radiologist, and then they go back to their GP to manage any additional findings that might be found, and also, of course, any nodules which may or may not look like are suspicious for lung cancer. There's some more details here about the various people included in the program, but it's basically everybody right across the health sector. So this is really important, and this is where we get to the interaction with pathologists. So that when somebody has a category 5 or 6 category 5 or 6 nodule, so that's a nodule that is suspicious for lung cancer, they are they're referred back to their GP. They get a letter from the National Cancer Screening Register saying go and see your GP. The GP gets a letter from both the radiologist and from the National Cancer Screening Register saying this is something we need to follow up, and then they go into a normal pathway to have their investigations. All that information gets fed back to the National Cancer Screening Register, and then if they haven't actually had any follow-up from that, the NCSR will contact the relevant health professionals involved to find out how. When somebody is then investigated, potentially with a bronchoscopy and a biopsy, that pathology data goes automatically and integrated back to the National Cancer Screening Register, and that's how we're sort of keeping this loop involved. And this is through this HL7 integration with the NCSR, which many pathologists will know already because it's what we use for the cervical screening program already. We have a whole lot of data access points where the NCSR will interact with the patient across their journey, starting with the GP who enrolls the person in the register, moving towards the radiologists who are integrated with the register. We've got about 60 or 70% of radiologists will be integrated by the end of this year. It's happening slowly over time, and that's a really important sort of connection point. Then, of course, when the person is followed up and has a biopsy of their category 5 or 6 nodule, that information then follows down to the National Cancer Screening Register. If a lung cancer is found, then the person exits the program. If no cancer is found, then the register will then send somebody a reminder form to have a repeat low-dose CT scan in 2 years' time. So we've developed lots of program materials for the program, and would really encourage people to go on to the National Lung Cancer Screening Program website, familiarise yourself with what the program's about. We have program guidelines which are pretty easy to read and contain all information, but we have a lot of fact sheets and shorter guides to get up to scratch with what the program is about. We've developed a lot of guidance, particularly for radiologists. The radiologist is a new way of working for them, because they are reporting nodules in a synoptic or systematic sort of way. There's exact wording which they're using for the nodules and for the actionable findings that they might find that are separate from lung cancer. And so we're working closely with RANSCA, the College of Radiologists, to develop education, webinars, online interactive education, and face-to-face workshops. We've also got an e-learning module, particularly for GPs, but for all people across the sector to participate into, and you'll find links to that on the program website. We've got a lot of supporting resources for patients about participating in the program, what to do if they're found to have a nodule, that sort of thing. And then there's a lung cancer screening helpline, and that's run by the Lung Foundation Australia, and we're thrilled to have that. That's staffed by nurses to assist people participating in the program. We've got resources particularly for Aboriginal and Torres Strait Islander people, and we've worked closely with NACCHO to develop those. So, just in closing, what's happened so far? So we launched the program on the 1st of July. As at last week, the 24th of October, we had nearly 30,000 people enrolled in the program, which was, exciting for us, even as much or more than we'd hoped. We only launched the public campaign in the middle of October. We've got about 257 participants per day. We're finding out their enrolment through a number of different ways, and this is how the NCSR gathers information. Importantly, we've found about 300 category 5 or 6 nodules. We expect probably about half of those to be cancer from our work done in the International Lung Screening Trial. So we are expecting to actually all of those participants will start filtering through to the respiratory physicians and then through to the pathologists as well. Interestingly, we've got quite a high level of what we're calling actionable additional findings, things that in the thyroid, adrenal, but also coronary artery calcification. There's been some breast cancers found through the program, all sorts of things that, of course, if you're imaging the chest, you're going to see in these things. But most of them are we're seeing as an advantage to the patient. A lot of them will be already known to the patient. So we will find, for instance, emphysema in patients with this smoking history, and most of those people will already know they have emphysema. But if they don't, then that's good for the GPs to know as well. So that's it from me. That's the website and a QR code if you would like to go into it to see all the resources. Thank you.
Thank you. Wow, that was such a great presentation, and Professor Milch shared earlier with me that even in the short time that the program's been running, they've picked up at least one patient who had a stage 1 lung cancer and was able to, asymptomatic, was able to get surgery and completely cured. They would never have been picked up otherwise. So that's the start of a very, very exciting program. Thank you. So our next speaker is a medical oncologist and cancer researcher with interest in clinical trials and translational research. So Dr. Ben Kong is a medical oncologist and consultant physician. He has a PhD in cancer immunology from Sydney Uni, and he consults at the Naloon Comprehensive Cancer Centre at Prince of Wales. Please welcome Dr. Kong.
Thank you, Sophie, for that kind introduction. I really appreciate the invitation from the RCPA to speak today to celebrate International Pathology Day, and I'm humbled to also represent my colleagues from the Thoracic Oncology Group of Australia today. Now, I've entitled my talk The Shifting Sands of Lung Cancer Management, and what I'd really like to do today is paint you a picture of what clinical management of lung cancer looks like from a clinician's perspective in 2025, acknowledging that there are many other important perspectives, many of which are represented in this room. There have been many changes in lung cancer over the past 5 to 10 years, and this is something that we as clinicians really struggle to keep up with. And so I hope to be able to paint you a picture of what this looks like in the clinic, and of course highlight the important role of pathology in diagnosis and treatment and monitoring of patients. I'm going to start off with this slide, which has already been mentioned, just to really highlight these numbers. And the numbers surrounding lung cancer in Australia are truly sort of shocking, even to a clinician who sees this on a daily basis. So it's already been mentioned that lung cancer is the leading cause of cancer-related death in Australia, and this is despite lung cancer being the fifth most commonly diagnosed cancer in Australia. So that's indicative of how serious this condition can be. And we've already heard that every year in Australia, 9,000 Australians succumb to lung cancer, and that number is quite staggering when we think about it. We're really fortunate in this lucky country to have lung cancer screening come into our daily practice. And I think the important thing to remember here, and something which is often lost in the message, is that lung cancer screening is really something that has been proven to work and reduce mortality. Lung cancer screening enables us to decrease the number of patients who are diagnosed at an advanced stage and increase the number of patients who are caught at an early stage where curative treatment can be very effective without any further treatment alone. Lately, we've also seen some changes in terms of the medical management of early stage lung cancer, and down the bottom here I've highlighted the recent use and PBS subsidy of neoadjuvant treatment. In other words, adding immunotherapy to cancer treatment before surgery, and this has also been proven to improve those very important survival outcomes, so over and above screening alone. So I want to paint a picture today of how heterogeneous lung cancer is. We heard before that lung cancer screening catches patients who have known risk factors such as smoking or family history. But it's important to remember that lung cancer is increasingly a disease that is thought of as many different separate diseases rather than one disease on its own. I've got a graphic here showing the pie chart for the sorts of molecular mutations that we might see in lung cancer and how they vary across different geographies. So even if you're at the back of the room here or online, you might be able to see the size of the red pie chart here. And those are the proportion of patients who have an epidermal growth factor or EGFR mutated lung cancer. And this is a type of lung cancer that was first described in females, typically non-smokers, typically of Asian background. However, we now know that that applies across many different groups. You might be able to see that on the one hand, we have the distribution in Asia, where this type of lung cancer makes up over 50% of cases. And on the other end of the scale, we have Europe, where that's a much lower proportion. And not surprisingly, in Australia, we sit somewhere in between. You can also see there are many other different pieces of the pie chart, and these are types of lung cancers that may or may not be associated with the traditional risk factors. And of course, knowing more and more about molecular pathology, we are finding more of these types of lung cancers and, importantly, seeing more different treatments coming through. I'm going to illustrate just with a couple of case studies what some of this heterogeneity in lung cancer looks like and some of the challenges that we are faced in the clinic and how pathology may help us to diagnose and treat these cancers. So the first case I'd like to describe is that of a 33-year-old lady, non-smoker and never smoker, who came to our institution after being transferred from a regional centre where she originally presented with chest pain. She was diagnosed with a laundry list of very acute medical problems, including having a chest mass, which you can see on the CT scan on the right. She had a newly diagnosed deep vein thrombosis and a pulmonary embolus. She had an infarction of her kidney and also had what we would colloquially term a heart attack. Very unusual in a 33-year-old lady, and this was found to be an embolic left anterior descending infarct, very unusual. This patient was previously well, although she had a very distant psychiatric history. She was previously well, and at the time of presentation, she actually presented with some features of confusion and psychosis, and her MRI brain showed multiple microemboli in her brain. So with her age and presentation, initially the thought that maybe this was a blood disorder and she might have lymphoma, so she came under the care of the haematologists. Now, it wouldn't be a talk about International Pathology Day without showing a little bit of pathology, and this is something that sometimes gets lost in the detail. But for those of you who are a little bit simpler like myself, the take-home message here is that this histopathology shows that this patient has a metastatic adenocarcinoma that has likely arisen in her lung, so with the typical sort of markers showing this. So the next question came up, what is this and what's caused this? And this is probably one of the only times in my career where we might be able to guess something ahead of the pathologist, and I thought with this clinical picture that this patient must have a genetic lung cancer, and we asked for her molecular pathology to be expedited. Within a week, our friendly pathologist called up and was very astounded that I could possibly guess what this was, and this in fact turned out to be a ROS1 fusion non-small cell lung cancer. So this is a type of lung cancer that has some modern targeted treatments associated with it. I'm going to describe another case, again in a non-smoker, a 64-year-old patient, and this patient had a very distant history of early gastric cancer. As you can see on her CT scan on the right, she had a small lung nodule that had been monitored over many years, and her treating clinicians thought rightly so that this was likely benign. And she was a very fit lady attending the gymnasium every day with essentially no other medical history. So this is a sort of case of something hiding in plain sight, and during the course of her surveillance, she began to develop the features on her CT scan above, which our radiologists reasonably called inflammatory changes, thinking that she might have some sort of atypical infection or something that might explain some of these findings. And I've been over these scans many times and really thought, again, how could we do this differently and come to the same conclusion? Only a matter of weeks later, the patient then came back feeling very short of breath and quite acute changes on her CT scan. And I received a hurried phone call from her treating physician, and this is exactly what we both thought at that time. What is this, and how can we manage this quickly with a very fit patient in front of us presenting with shortness of breath again? So again, this was another case of a rare mutation that we wouldn't have discovered if it weren't for rapid access to molecular testing in lung cancer. And fortunately for this patient, we were able to find a targeted treatment, which, as you can see, had a very marked effect on her lung cancer, not without its own side effects. And she had some heart failure from her treatment, but remains well to this day. Now, these two cases are just illustrative examples of relatively rare but increasingly discovered molecular lung cancer, and these cases can only be diagnosed with the help of pathology. Fortunately, now we're seeing more and more targeted treatments, and the title of this slide is something that I never thought we would say 10 years ago, and we are now starting to refer, in some cases, to survivorship in lung cancer. Patients who may have been treated for an early stage lung cancer who are cured, patients who have been lucky enough to obtain benefit from immunotherapy, and even patients such as this patient, who is a patient of mine who has been on treatment long term for her ALK fusion lung cancer, and as you can see has gone on to think about many things that we do think of as normal part of life. And obviously for oncologists this leads to many challenging conversations in the clinic in an evolving space. So you can see here, this is an example of how in one type of lung cancer we've seen many developments and new treatments and drugs over a very short period of time. This brings me on to the topic of liquid biopsy. Not all patients fit into the boxes for screening. Not all patients can have adequate biopsies that will afford that diagnosis straight away. And with patients being on treatment for longer and longer periods of time, as clinicians, we obviously want to know about things like resistance mechanisms and how to use new drugs. And I've highlighted here some of the recommendations, which Professor Cooper will go through in more detail about the recommendations for the use of both molecular testing and liquid biopsy in this setting. The potential advantages of liquid biopsy are that it's non-invasive, it allows real-time monitoring of mutational burdens, and also allows additional targeted options for patients. But of course, to implement this, we need to navigate the regulatory framework for drug reimbursement and the health economics of population-level implementation. So this is where some of the work of the thoracic oncology group is coming in, and the Aspiration 2 study is one of just several studies looking at this implementation. The reason this is called Aspiration 2 is because this leads from the Aspiration trial, which generated the evidence to help us implement molecular testing, and this is specifically looking at the role of liquid biopsy in stratifying patients to determine the feasibility, clinical and economic impacts of liquid biopsy. And we're really after a national framework and generating the evidence to implement this in all of our suitable patients. This is just a brief outline of what the Aspiration 2 trial looks like. We are seeking patients who may be on a current targeted treatment and have progressive disease, and essentially looking for that needle in a haystack to try and match these patients to new targeted treatments based on their resistance mechanisms that we may find in a liquid biopsy. And you can see down the bottom here some of the important aspects that we need to navigate whether we put these patients on PBS-funded therapy, pharmaceutical company access programs, or even novel targeted treatments as a result of their testing. All right, so just to summarise the key points that I think are important to take home today: the important role of lung cancer screening, which is key in improving survival from lung cancer. Not all patients benefit from lung cancer screening, and therefore we must be mindful of the many other different types of lung cancer. And increasingly we are seeing many other types of lung cancers, including rare mutations or mutations that inform how we treat these patients. And this is where the key role of pathologists come in managing our patients and looking to making our clinical management even better than it already is. Thank you.
Thanks, Dr. Kong. That was such a good presentation. So many interesting case studies and a really optimistic picture of how far we've come, really, when it comes to diagnosing and getting people treatments that can save their lives. So following on from that talk, we're going to continue this same topic. We're going to hear from the RCPA Chair of Cancer Services Committee, Professor Wendy Cooper. She's a Senior Staff Specialist Pathologist at RPA, and she's the Anatomical Pathology Clinical Stream Lead for New South Wales Health. And She's got a lot of long laundry list of things that she's done when it comes to lung cancer. She's on the Pathology Committee for the International Association for the Study of Lung Cancer and a member of the expert panel for the International Molecular Testing Guidelines. And then she's going to speak about the guidelines and also a bit more about liquid biopsies as well. So please welcome Professor Wendy Cooper.
Thank you, Sophie. And thank you to RCPA for allowing us to acknowledge lung cancer on International Pathology Day. I think it's really timely given the introduction of the National Lung Cancer Screening Program in Australia. So I'm going to be talking about the role of pathology in zeroing in on lung cancer. We've heard today what a big impact lung cancer is on Australians. Even though it's only the 5th most commonly diagnosed cancer, it's a leading cause of cancer death. Over 40% of lung cancers are diagnosed when patients have disease that's spread distantly from their lungs and it's not curable. It can be controlled to some extent, but not curable at that stage. And early diagnosis is critical to improve outcomes. Diagnosis at that earlier stage where we can cure patients. And so for that reason, I'm so excited that we've got the National Lung Cancer Screening Program in Australia. That's given us the opportunity for these patients, these high-risk patients, to be diagnosed at an earlier stage where we can have greater cure rates. And that's going to have a really good impact on mortality of lung cancer in Australia. It's going to shift the stage to the stage of diagnosis to earlier stage disease. And pathology is critical in that, in making that original diagnosis. So we've heard that patients on the CT screening, they get diagnosed as having a category 5 or 6 nodule if it looks worrying, and only about half of those will actually be lung cancer. We need to make an actual diagnosis on that, and that's where pathologists come in, and we confirm whether or not that patient has lung cancer and what type of lung cancer it is so that we can give them the best care possible, as Ben's told us about. So it's not only diagnosing those lung cancers, there also are those incidental things that we discovered, the thyroid nodule, the breast cancer that might also be picked up, and that's where pathology will come in as well. And it's not only the lung cancer screening program, it's any patient diagnosed with lung cancer. We know that lung cancer screening is only available for those really high-risk patients because that's where the cost effectiveness comes in. But we know that there's many other types of lung cancer, and these patients don't always have these risk factors. And yet all of these patients, all of them will benefit from having accurate pathological diagnosis to inform their treatment and accurate and timely molecular characterisation to inform their treatment, whether they've got early stage or advanced stage disease. And again, that biomarker testing is done by pathologists, and that's where we form that critical part of that multidisciplinary team to manage lung cancer patients and improve the outcome. So in lung cancer screening, I think I've already said this, the pathologist will diagnose that what actually that high-risk nodule is that the radiologists have identified. Then hopefully a patient will be diagnosed with early stage disease, so we'll examine that resected specimen and do the molecular characterisation that'll inform whether they should have had, if they've had need neoadjuvant therapy or adjuvant therapy, and participate in the multidisciplinary care meetings that inform and help determine the optimal treatment for these patients. Another really important role that pathology, and in particular RCPA, has had in collaboration with ICCR is developing evidence-based structured pathology reporting protocols for our cancers and lung cancer in particular. And just how we heard that the radiologists in lung cancer screening have structured reports so that nothing is missed out, we've got evidence-based structured pathology reporting protocols for our cancer specimens, making sure the tumour classification, the staging, all the prognostic parameters and the predictive biomarkers are covered, so nothing is missed out for any of the patients. And it's a prerequisite for best clinical practice. It enables people like Ben to institute the appropriate care for our patients. And it's also important for epidemiological research, for public health measures and benchmarking in cancer management. We heard as well that lung cancer is not one disease. Patients have different risk factors. And even amongst those two commonest types of lung cancer here, on the left, lung adenocarcinoma and lung squamous cell carcinoma on the right, they're very heterogeneous groups of diseases. No two lung cancer patients are the same. But what we can do is subclassify what type of lung adenocarcinoma in particular a patient has based on their molecular profile, based on those tiny genetic changes that are driving that tumour, because that could inform the best treatment, because there's fantastic treatments available that target some of those specific alterations. And we'll hear from some patients later, and in particular, Chanel, who will tell us her story about an ALK-driven lung cancer. I'm very fortunate where I've worked. We instituted molecular testing quite early, and I was very fortunate, and I'm very grateful to the opportunities that Professor Sandra O'Toole gave me at Royal Prince Alfred Hospital, because she was setting up the molecular laboratory, and me being interested in lung cancer, it was a great opportunity to get that set up. And I specifically remember, I was sitting there just earlier and thinking, I remember the first ALK-positive lung cancer patient that we identified using FISH, and it's very powerful because you know that makes a big difference to those patients. It's going to change their treatment and their outcome. But there are many barriers to molecular testing and to getting molecularly driven treatments in lung cancer patients. This is a survey that the International Association for the Study of Lung Cancer undertook, and Australia contributed. And you can see that the top barriers are getting enough tissue for us to work with as pathologists to be able to make that diagnosis and do that molecular characterisation, the cost and the time, how quickly we can get those results. We've heard some of these patients are really sick, they need the results really quickly. We can address some of those issues in pathology. So one of the things we did from RCPA is we put in an application to MSAC, so the Medical Services Advisory Committee, a few years back, that was successful and very, very dear to me, and I'm very grateful to the college, to the support and enthusiasm from members to get this over the line, where we got reimbursement from MBS to do next generation sequencing testing of all these incredibly important molecular biomarkers in lung cancer, and that's been a game changer. Before that, we only had reimbursement for a single gene testing here and a single gene testing there. This way we could do the whole range of markers that we needed to test on tissue. But we realised tissue isn't always possible to get. Sometimes we don't get enough tissue from a patient where you can only just get enough to make a diagnosis. We don't always have enough left to do the molecular testing. Or sometimes a patient is critically unwell, that patient with all those thromboemboli. I'm surprised you could wait a week to treat that patient. Sometimes a result is needed faster than that if someone's really unwell. So we have supported another application that's going through the pipeline at the moment. We hope it will eventually get up, but we're seeking funding for liquid-based testing. So to do the same range of testing, but on a blood-based test, where tiny amounts of the DNA from the tumour have shed into the bloodstream and can be identified on a blood test. So we'll see how we go there. Another thing that we did through the college was to come up with, come up with, devise and publish our molecular testing of lung cancer evidence-based best practice recommendations, which we launched and published earlier this year. We did it in partnership with the Thoracic Oncology Group of Australasia because we needed that clinical input where a multidisciplinary care is required in lung cancer. And you can follow that QR code there to see all of them. I'm not going to go through every one of the key recommendations, but they're very comprehensive, 16 recommendations. I'll just cover a few of the key ones. So in advanced stage disease, we recommend testing for all of those genes across the top there, because we need to identify exactly what's driving that tumour so that a targeted therapy can be used if it's available. And this testing should be performed on reflex by pathologists. We should know straight away if we've made that diagnosis, this information is needed, we need to get on with that testing and get it done quickly. So that's how we're addressing that turnaround time as well. But it's not just in advanced stage disease where targeted therapies have an impact. Now in early stage disease, we need to know the molecular makeup of the tumour as well, because that also informs treatment decisions and will impact the a patient getting their optimal care. So in particular, at a minimum, we need to know the epidermal growth factor receptor status, ALK, ROS1 and PD-L1 status, because that will inform what neoadjuvant therapy might be appropriate, or what adjuvant therapy is appropriate. And I think this will evolve over time. We might need to broaden that as well. And we also made recommendations about which specimen types are optimal. We deal with many different specimen types as pathologists, and we've really got to make a small amount of tissue go a long way. And we've got recommendations to make sure we're doing that to try and prevent patients from undergoing unnecessary procedures that they obviously don't want to have, but they also cost the health dollar a lot. So part of the recommendations, we do recommend that blood samples for ctDNA, the liquid biopsy test for molecular biomarkers, are suitable for molecular testing in certain clinical scenarios. So particularly if a tissue specimen is inadequate, or if the results are needed really urgently, this is where there's a role for liquid biopsy. It's not currently reimbursed by Medicare in Australia, so that does raise equity issues, and that's why we've supported that MSAC application to try and seek funding for that in those limited clinical scenarios. So I just want to end up by saying that pathology is a crucial part of zeroing in on lung cancer, and I think Australia as a whole, we're addressing that leading cause of cancer death. The lung cancer screening, together with advancements in treatment, will reduce mortality of lung cancer in Australia. I've no doubt about that, and I really look forward to seeing that data come through. I can't wait for it. And pathology underpins the diagnosis of lung cancer and molecular characterisation required for the optimal treatment decisions, and I'm really proud to be part of that. So thank you.
Thank you very much, Professor Cooper. Thank you for that. It shows, I think that your presentation really showed just how important it is that we know what those biomarkers are, we know what those genetic features are, so that we can really optimise people's treatment. So now I'm really delighted to introduce our two patients to you all today. I'll get them to come up. We're all going to come over here. I think this is on. Good. Come on over. So we've got, come and sit up here. I'll introduce this as Martin. Martin is an architect from Mossman. Give them a bigger round of applause. Come on, that wasn't much of a round of applause. That's better. So Martin is an architect from Mossman. And we've got Chanel here as well. I'll just tell you a bit about Martin's story first. So he was diagnosed with lung cancer in October 2019, and he had an operation to remove the cancer, and that they took out half the lung, and that the surgery was successful. And he's going to share a bit more about his journey and how he's become involved now as an advocate and a patient representative on groups like TOGA. And then we have Chanel. So Chanel is an artist from Surrey Hills, so you didn't have far to come this morning, which is good. And in early 2023, she had an annual thyroid check, but the doctors found something suspicious, and she'll explain what they found. And as we'll talk about, Chanel had the genetic biomarker testing that we have been hearing about, which confirmed that she had the ALK positive non-small cell lung cancer. And then from her results, the team looked at 2 treatments that might be helpful, and we'll talk about those and the benefits of those treatments. So I might just start with Martin first. Can you just talk about what were the symptoms that led you to have a diagnosis? Because they're both on. So we've talked about screening, but now we're sort of moving to both patients were incidental findings, and outside they wouldn't have been picked up by screening.
For me, it was I had this persistent cough, like there was something on my lung that I just wanted to expel. And then after about 3 or 4 days of that, I was able to expel some phlegm, and it had a bit of tinge to it. So this went on for maybe a month or so, and then I realised, with the help of Dr. Google, that maybe I should go and see my GP, which I did. And my GP had a look at it and said, well, there's something wrong there. And she sent me off for some x-rays, which weren't conclusive in any way. So she waited a bit to see if anything changed. It didn't. So maybe a week or so later, she sent me off to a specialist who, through discussion, sent me for PET scan, I think, and a CT scan. Came back and there was growth on my lung. She said, she didn't say it was cancer, she said could be cancer, cannot be cancer, but it's going to come out. So I was booked in for surgery, and in the meantime, sample biopsy was taken, sent away, came back, confirmed cancer. So then I had surgery. Doctor said it's close to, it's in the bottom lobe, it's close to the junction between the top and the bottom lobe. I'm going to take out the bottom lobe. If it's crossed the barrier, do I have permission to take out the whole lung? Because it's hard to ask you that on the table at the time. And I said, sure, whatever you need to do. So I had that. Was in hospital for about 72 hours of recovery. And then, so that was probably between the August 2019, had the operation in December 2019. Come the January, I got a call saying we booked you in for some chemo. Saw an oncologist. She said, we want to try some treatment, but it's up to you. The risk of it recurring is so much, but with a bit of chemo, it sort of jumps maybe 5%, up to you. I said, sure, give it a go. Had chemo for, it's going to be 3 months. That was the start of 2020.
Other things were happening in January 2020 at that time, weren't they?
Yes,
Like the
so
pandemic?
COVID came along, and I didn't do my last treatment because they said, because the hospital was sort of getting ready to almost shut down, and they said, well, the risk of getting COVID is greater than the benefit of your last treatment. So that was start of COVID in 2020, and then this year, 5 years of cancer-free, so now I'm cured.
Yay, that's fantastic, Martin. That's awesome. And so that's a fantastic result in that you're well, but you wanted to share your experience and join TOGA, which we've heard that Dr. Kong is a member of as well. So tell us a bit about the role that you play there. You are on their consumer advisory panel, is that right? Looking at research and things like that?
Yeah, so my oncologist suggests that maybe I might suit joining TOGA because they did show interest in what was happening to my body. And I was keen to give back to the health system what I could. I didn't quite know what that meant because all I've got is my story. And I'm willing to tell anybody who wants to hear about it. But through TOGA, I'm on the consumer panel, and recently I was asked to review some submissions for trials for funding from a consumer point of view, which from what I can see is that TOGA is really pushing that consumers are part of the process. I also on a consumer panel with St Vincent's Hospital, and they're really part of, they need to have people on their consumer input and consumer panels. So it's quite fascinating what goes on behind the scenes. I never knew what a pathologist did. I'm still not sure I do.
Well, hopefully after today you know a little bit more about what they do.
Those last few presentations have been so informative, and apart from a few words I didn't understand, a few acronyms, I think I got the gist of it. So I think that's helpful if that sort of message can get out to the general public. That's like, I've got cancer, what now? In words of 2 syllables or less. 2 syllables or less. So with TOGA, I realised that there's a lot of people worse off than me. And so I feel that a lot of sharing of people's journeys helps one another. Because the more you talk to people, the more they'll share their story. And I think having cancer becomes less of a stigma and less sort of unknown and pushed to one side. I see with people of my vintage a lot more prostate cancer, and people talk about it now, and it's no big deal. It's just like, oh yeah, I have that. Every second bloke has it, it would seem. And breast cancer gets talked about a lot more, and people are doing a lot more to find out about it, I think. So
Yeah, so it's good that we're doing that now for lung cancer as well.
yeah,
Talking
I'm
about
happy
it. Exactly.
to say I had it.
Yeah.
And I didn't realise that there was a bit of a stigma attached to it, but that in the last 5 years, that never came up anywhere.
That's
I never
good.
felt people were sort of judging me. It was never spoken about. It was just, oh. It's only recently I realised that maybe there was, but
That's a good reflection that you didn't experience any of
Yeah.
it. So thank you for sharing that, Martin. Now, Chanel, can you just tell us a bit about your experience? Because like Martin said, everyone's journey is different. So just take us back to, so you were having regular thyroid tests for other reasons. So what happened when you had that thyroid test in 2023?
Yeah, the sonography.
I might just get you to hold it nice and it should be on. Yeah.
Is that good?
Yep.
That test in 23 was actually meant to be my last just routine check of the thyroid, and because I had been having it checked for like 20 years and nothing had come up, so my GP was like, let's just make this the last one. And the sonographer found just an enlarged lymph node right next to the thyroid, and we had it biopsied, and luckily I was an amazing oncologist that ordered a ultramicron precision assay that tested for those, I think it's 50 hotspot genes that have targeted therapies, and it turned out I had positive lung cancer, and it was very advanced. It was stage 4B, incurable at this time. But the targeted therapy worked immediately very well. It's also interesting, I think, to note that I was diagnosed with no symptoms.
Wow.
And that's often the case with this particular variety of lung cancer. A lot of younger patients diagnosed at a very late stage with no symptoms.
So tell the audience, you started on one type of the targeted therapy, the first drug,
That's right.
alectinib, and that worked well, but then tell them what happened with you decided to swap to another one.
Yeah, the alectinib worked to reduce my disease to almost undetectable within the first 6 months of treatment. But in the 2 years that I was treated on alectinib, which I tolerated really well, another drug called lorlatinib had been in trial, and in, I think, it was about 6 months ago, maybe a year ago, the 5-year trial data on that drug was released, and the results were just so good, it kind of just blew everything out of the water. So I decided to switch over because the efficacy was
just amazing.
The evidence was there that it was just going to be a lot more effective for patients.
Amazing. And so what's been your response to that second drug that you went on?
It has a totally different side effect profile to alectinib, and it just coincidentally suited me better. I'm really glad not to have the fatigue and muscle pain that I experienced with alectinib. But now, so instead I just have some nerve pain and some mild swelling that's kind of, it's just manageable. But I have a really good quality of life. It means that I can still go to the studio every day and just kind of do my life as I was. It's kind of incredible to be living with terminal illness and not really having to change very much.
Amazing. And it's been very effective in terms of getting rid of the cancer as well, hasn't it, for you?
Oh yeah, at the moment I also had a surgery. I had a lobectomy. I had my lower right lobe removed in January this year. And since that surgery and switching
medications. I now have no detectable disease, not even on a minimal residual disease liquid biopsy.
That's amazing.
It's like very low.
Wow, that's so good. And just on that point, so you had a couple of liquid biopsies throughout the treatment.
Yeah.
Can you just talk about why you think it's so important that there is such close surveillance of people with lung cancer with things like liquid biopsies?
Yeah, well, for me, one of the strategies that I really want to employ in order to get the most out of this particular drug, because it is working so well, and there's not a better option available at the moment, is a highly sensitive monitoring system to catch any kind of even tiny progression at a very early stage, so that it can be treated and I can stay on the drug. So if there's like even just a few rogue cells that go and the liquid biopsy shows something, then we can do another PET scan and maybe zap them if we can see them, or do another round of consolidative chemo to knock it down again, and I can stay on the drug. That is giving me such a good quality of life. And the main tool, I guess, in that scenario is having the most sensitive monitoring you possibly can. And at the moment, that's ctDNA testing. And at the moment, I'm getting it through a company in the States. It's a test called Guardant Reveal for minimal residual disease. And it's very costly. And I hope to be doing it every 3 months so that I can ideally push my CT and MRI scans out from 3 to 4 months and not feel like I'm losing any efficiency in the surveillance. And being able to push out that testing as well after that kind of harmful scanning is something that is starting to become like really important to me after 2.5 years of treatment, especially looking to kind of live a long time on this drug. It starts to become more and more important.
Amazing. So we've got, some of Australia's and the world's leading pathologists in the room and watching, and I just want to finish by getting you to really just sum up the main message for both of you, what you want them to know about your experience, what you want to share from everything you've been through. Chanel and then Martin.
I think the main message is like how much I appreciate molecular testing. It meant that I could get on a really efficient treatment very quickly from like my initial test to being on a treatment that was working really well was 3 weeks. And I have a really good quality of life because of it. And it's also really important that patients have excellent accessibility to really highly sensitive monitoring so that they can get the most longevity out of these amazing drugs.
Fantastic. And Martin, what about from you?
I guess it's sort of say thanks for what you do.
Well, that's appropriate because we're here to celebrate pathologists, so that's highly appropriate.
I wish I said that.
No, yours was good too. Yours was too good.
Most people probably don't even know what a pathologist does when they go to hospital. I suspect a big percentage don't want to know. They want to get in and get out. Some people like to delve into the whole system. I do. But unfortunately, we don't usually get to see our pathologist.
And it's only when you become unwell that you realise how important pathology is to
when you
becoming well
do
again.
look at it, you realise they're the key to your treatment, really. And I guess we need them, but they need us too. Although they probably wish they didn't need us. Yeah. I mean, medicine is, like in my field, you want repeat clients. I gather in medicine they don't.
It's not quite the same. No. They want clients that they can get well and never see them again. That's the ideal client in medicine.
That's right. Yeah.
All right, please give Martin and Chanel a big round of applause. Thank you both. I'll just get you to leave that here. So we're now going to move on to our panel discussion. I'll invite back Dr. Ben Kong, Professor Wendy Cooper and Professor Vivian Milch to come up. Come up here. Come on up, we'll just get you to grab a microphone. Now, I'll just ask you a few questions and then we're going to go to the audience questions as well. So please be thinking about your questions. So some of it we've already covered, but we heard the stat that lung cancer is the leading cause of death. And why is that, Professor Milch?
Yep. So one of the reasons that it is the leading cause of death is that, generally speaking, until now, it's been diagnosed late. We heard from Chanel that she was still asymptomatic, even with stage 4B disease, and that actually is quite a frequent story that people, we've been working on helping GPs recognise symptoms of lung cancer for years, and we have a GP guide, and we try and talk about the symptoms to look out for, but often by the time somebody has symptoms, they've already got advanced disease. So even people who are reacting quickly to those symptoms, or the GP is reacting quickly to those symptoms, it can often be late. So that's one of the reasons. One of the reasons, of course, that we have a lot of lung cancer is related to smoking. Smoking is the leading cause of lung cancer, even though we've heard from two consumers, patients who have not had a history of smoking, but it still is the most common cause of lung cancer. And I think that one of the things about smoking is there's a lot of shame, a lot of embarrassment, a lot of stigma involved in smoking. But smoking is highly addictive. It's the cause of, it's caused by big tobacco. And I think that, taking away this sense that it is the patient's fault, we have long history of, for instance, Aboriginal and Torres Strait Islander people being paid with cigarettes. It's a big problem. So, and because of that stigma, there might be a sense of not really wanting to go along to the doctor when you have a symptom, not really wanting to know. But then coming back to what we heard today, there's been a sense of nihilism. That, well, no point in going to the doctor about these symptoms because there's nothing I'm going to be able to do about it. But now, this with the change in molecular testing, with the new targeted treatments, we have an enormous number of things we can do about it. And so changing that story is also really important.
Fantastic. And I just want to move on to a bit more about the screening program. So, Professor Cooper, what makes pathology so critical to the success of the screening program?
Yeah, I mean, ultimately the screening program's about diagnosing lung cancer, and the radiology is really just screening and detecting a high risk nodule. It's just the first start of the journey for that particular person, that particular patient, but accurate, timely diagnosis of what that nodule is critical, and feeding those results back into the program accurately so we can close the loop and assess how frequently we're diagnosing lung cancer from that screening, getting the correct diagnosis so that the appropriate treatment can then take place.
And what about, Professor Milch, patients who aren't eligible for screening? How do we, and maybe Dr. Kong as well, how do we capture those people as well?
Yeah, so there's a couple of things. First of all, that we do need to be aware of symptoms. We heard Martin had a symptom, he promptly went to the doctor about it, the doctor promptly investigated it. So that still is it's a critical part of patient care. But the other thing is that this is an agile program. We started with a group of people who are high risk for lung cancer. It's quite a narrow population that we're looking at, people 50 to 70 with a 30-pack-year history who are either smoking or have quit in the last 10 years. But we expect that to change over time.
To be broadened out?
We hope that over time it will be broader. And so we have a research program within the lung cancer screening program to be looking at how we can actually make this a program different and broader over time. It will move with time. We won't have the same program in 5 or 10 years' time as we have now.
And I just want to move on to, we heard Chanel's fantastic experience with targeted therapies and the great results that she's had. So, Dr. Kong, are you seeing similar results with some of the patients you're looking after as well?
Yeah, certainly. So I think just putting this into context, over the past decade, we've seen perhaps some sort of 10 or 11 targeted therapies come into use. And as I said before, we're really lucky in Australia to have access under the PBS to many, if not all, of those treatments. So as you've seen today and through Chanel and Martin's story, sometimes the responses to those treatments are quite dramatic, and now that these are being used more and more, we're starting to see what the long-term positive effects of some of those treatments are. So finding more types of molecular pathology, molecular types where we can use new treatments is really important going into the future.
So at the moment, if someone comes along with lung cancer, would they be offered molecular screening or those genetic tests routinely, or is it something that they just, like I asked Janelle, did she ask for this or did her oncologist suggest it? What's the sort of standard treatment?
Yeah, I think it's fair to say that molecular testing on tissue is something we would really consider as standard of care.
For all cancers or just for lung cancer?
For lung cancer in particular, because of those targets, although in many other types of cancers we have sort of analogous targets that may be
like
tested.
Breast cancer and other things,
Correct, yeah. So I think the important part from a system point of view is access to that, and of course we have sort of the tyranny of distance in Australia and other factors that must be factored into that. And as specialists, we are lucky we sometimes have these things presented to us on a plate, but the reality is that these cancers are diagnosed in the community, and that might mean any sort of healthcare setting.
So I've only just got a couple more questions, then we're going to go to the audience in the room and also online as well, if you've got any questions. So maybe Professor Cooper, just on the issue of molecular testing, why is it so important, and what makes it so, is it challenging as a thing to do for lung cancer, given you're literally written the guidelines on this?
Yeah, it can be challenging given that we typically only get really small biopsies for lung cancer. Because most patients are diagnosed with advanced stage disease, they'll just undergo a small biopsy or cytology procedure. It can be difficult to get samples from lung, particularly from the lung periphery. So very small amounts of tissue from which we need to make an accurate diagnosis. There's many different types of lung cancer, so we use up tissue to do that. And then to do this broad panel testing covering all of those range of genes, we need to get enough DNA and RNA out of the sample. So we try to optimise everything we do to maximise the chance of getting those results.
Fantastic. And just sort of projecting a little bit forward, Dr. Kong, into the future, what do you think the next challenge will be, or the next frontier for lung cancer care? What are you seeing coming along that the audience might see in the future?
Yeah, that's a great question. So I think we can sort of approach that question from a few different angles. One of them is lung cancer screening. I mean, we know the benefit of that, but getting patient and community engagement is key to the success of that program. It's not a matter of just funneling everyone into the same pathway. At the other end of the spectrum, I suppose, in advanced disease, although we know about many of the molecular targets through some of this testing, we're discovering even more, and so trying to find the best ways to test these drugs and show that they're effective and also cost effective, especially in our system, is the challenge, and that's one of the goals of some of the studies that we've described today.
Fantastic. So we might just go to the audience questions now, both in the room and online. So if you've got any questions in the audience, just raise your hand and we've got a microphone here. Yep. Thank you.
Rob Bird, I'm a haematologist from Brisbane, so excuse me if I've completely missed the mark. So you've mentioned how with the radiology screening, the GPs really the pivot to investigating incidental findings. So I'm wondering, with the molecular testing, if you have a variant of very low allele frequency, do you report that? And if so, how does the clinician deal with it? Or is there a threshold? And variants of unknown significance, if that's reported to the clinician, again, how do they deal with it? Because certainly in haematology, we now get a lot of reports of very low variant allele frequencies. You know, we call them chip mutations, clonal hematopoiesis of indeterminate potential. Is there an analogous situation in this testing, and if so, how does a clinician deal with it?
Yeah, I think that's key question 14, if I'm not mistaken. It is in one of the things we address in the molecular testing guidelines, the sort of technical aspects of thresholds and what to incorporate and what not to. We do have a bit of an advantage in solid tumours in that we've got the tumour cell content that we assess, and we can compare the variant allele frequencies with the tumour cell content, so we can determine whether we think that's an oncogenic driver or some sort of subclonal population that's unlikely to be of clinical significance. And we do give the tiers of classification of the relevance of those variants that we identify, so that when it gets to the oncologist, that they've got an idea of what to do with that. And they're very well informed these days too, I must say, in general.
We're trying to be. I think just to add to that as a illustration of that, one of the things I didn't mention earlier is that the sort of most common mutation in lung cancer is actually in the KRAS gene, and this is one of those things we love to sort of torture our trainees with, and up till now that hasn't been something that's been targetable, but we are starting to see some drugs come into that space. But as with everything in molecular pathology, it's not just sort of one type of gene just to confuse us. There's a whole alphabet of KRAS genes, and we're getting to the stage where we're having sort of clinical trials. We're looking for that sort of needle in the haystack, and as we've seen earlier, that can sort of turn into a very commonly used drug, such as in ALK lung cancer.
Fantastic. Good question. Okay. Anyone else questions from the room? Or we might see if we've got any online questions. If we don't have any more from the room, any from online? I might just have, I've got one or two that I can ask. One was, and I think it's sort of been alluded to, but how important is it that we've heard about some great advances today, obviously with the molecular testing and the targeted treatment, but how important is it that we have, that all patients have faster access to it and funding for these great technologies and medicines? Can I ask Dr. Kong and Professor Cooper? Yep.
So that's a tricky question to answer. I think the important thing is rapid access, as we've seen in individual patient cases, but also for clinicians and patients and consumers to work together to find the right balance between rapid access where some treatments may be ineffective or do harm, and balancing that with the need to advance things quickly, because no treatment is ever going to come fast enough for an individual patient, of course, but working in the system, we need to sort of...
And is that why in one of your slides you showed some of the current studies that you're doing at the moment to see sort of quality of life and cost effectiveness and things like that, for that very reason?
Yeah, correct. To show that works at a system level
as well as individual.
Yeah. And I think that's one of the things that we do as part of the college is to provide advice about what we think is the most clinically appropriate, the most clinically valuable tests to do. There's so many fantastic things out there in research. Not all of them are going to come into clinical practice and be of value. And so we're in a position to be able to make that evidence-based judgment about what we think is a clinically relevant test to be funded publicly.
Amazing. All right, so if we don't have any other questions, which is great. Your presentations were all so good that the audience is so well informed now, but please give our panel a big round of applause. Thank you. Come and sit back down, and I've only just it was a great discussion, and there's so many great advances, and it sounds like there's so much potential for more to come as well, which is really exciting. So I would like now to introduce, which is very exciting, the just elected new college president, Dr. Sandra O'Toole. Most of you will know her. I've certainly, she's been in the media and I've done lots of interviews with her. She's a professor of pathology at Sydney University and a senior staff specialist in pathology at RCPA. And she's also a Eureka Prize winner as well for part of a team for her work in breast cancer microscopy. So please give her a big warm welcome. Is this your first job as president? There we go. Her first day on the job.
Thank you very much, Sophie. It's really lovely to be here, to see you all here, and good afternoon. And we've been very grateful to have a long-standing relationship with you at the RCPA, so long may it continue. Really appreciate your help in getting our message out about the importance of pathology to the health of Australians. So I'm really delighted and honoured to be addressing you here today in this new role as President of the Royal College of Pathologists of Australasia. I'm really passionate about the role pathology plays at the centre of modern healthcare, and that the role pathologists play in helping ensure rational, timely and quality healthcare. So International Pathology Day is a time to reflect on the impact of our profession. As a breast cancer pathologist and researcher, I have been fortunate to have a front row seat throughout my career to witness the remarkable advancements in outcomes in breast cancer. And that's really been driven by screening, where I've been fortunate to work with Professor Milch for many years at Cancer Australia, through excellent pathology, and also working with our oncology colleagues who now have these amazing targeted therapies. And I think it really shows the importance of multidisciplinary care. And that we all communicate well together and work together. So after today's presentations, I'm really confident we'll start to see even more improvements in outcomes for lung cancer patients as well, with earlier diagnosis and targeted treatments. Lung cancer research is really leading the way in genomic testing, and I'm really proud to be part of the profession that is working to help transform treatment options. Today we've had a masterclass that really has shown how Australian pathology and our medical colleagues as well are really working to support precision medicine. And I hope you've understood from Wendy's presentation, she really is a world expert in this area and really leading the field, and I'm really proud to see the great work that Ben is doing too in important trials at Toga, and of course screening with Vivian as well. So the future possibilities are exciting, and the RCPA is working hard to ensure that we have a well-trained pathology and, very importantly, a scientific workforce to help us make this a reality. I'm looking forward to meeting with members of this valued workforce at our next scientific meeting, which is Pathology Updates 2026 in March, which will be held in Sydney, and I hope that many of you online and in the room will be able to attend. Thank you for joining us today during Lung Cancer Awareness Month and to celebrate International Pathology Day. Thank you to our speakers, Professor Vivian Milch, Dr. Ben Kong, Wendy Cooper, but most importantly, our patients. So thank you, Martin and Chanel, for joining us and really sharing your stories of what must be incredibly traumatic and emotional experiences. While we don't get to meet patients face-to-face that often, I want you to know that your story is always at the centre of what we do as pathologists, and we're always thinking about the impact of what we do. And while you may not see us, we are thinking of you, and it was wonderful today to hear from you so that people here in the room and our colleagues online get the opportunity to see the impact of what we do. And special thanks to our amazing MC Sophie. So this ends the official part of our event today. I hope, I'm sorry for those online you can't join us, but here in the room, please join us for refreshments in the foyer, and thank you to everyone.